All right, got it. All right, thanks, Lauren. So today we're gonna discuss some conceptual debates that are happening within the field of global health, which I know a lot of you are involved in as part of your degree or research projects or work, or even your day-to-day life. So I think it'll be interesting. I should speak for around 35 minutes if I'm good at timekeeping. And then hopefully we can open up the floor for some interesting discussion, which I would very much enjoy. If you can and you are willing, I mean, I'll be honest, engaging with students and presentations with at a virtual space, it's harder for a person like myself as a facilitator and an educator. So if you feel comfortable and you want to turn on your camera so I can more or less understand how your energy level is doing, if I need to speed up, if I need to clarify something, that would be much appreciated. So if you are in a space that you are able to do that and you feel comfortable with that, please, that would be much appreciated. Of course, I'll be sharing my screen, so I would only be able to see some of you, but that is always very useful. I'll try to engage with you with the use of emojis. So if you haven't used emojis, they're at the bottom right of your kind of lower panel in Zoom. You see reactions, and then you can kind of clap or thumbs up, or there's a variety. I usually like to use this party one. So if you can do this right now, can you just show me that you're listening to me clearly and you understand me? Just show me whatever emoji reflects your mood currently. A lot of thumbs up, which is good. Linda, hi. Linda was in my class just recently. I don't know. She
Hello.
did.
I'm not putting on my video because I am eating lunch.
No worries. This is lunchtime, so I understand that. So yeah, so great. So I'll introduce myself now. Thank you for everyone for reacting. My name is Carlos Alberto Faerron Guzmán. I'm actually calling in from Costa Rica. I'm a Costa Rican. I've lived and worked here for most of my life. I trained as a physician, but veered into a career into global health. And I consider myself first and foremost an educator. So I ask in my work research related. I mean, my work is more education related work. So I like to work in the innovation space in education. So I design curriculum and programs and work at different institutions doing that. So although I haven't practiced in 6 or 7 years medicine, that is my background. So that's where a lot of these perspectives do come, and I borrow from that. So I hope that today's conversation is interesting. The other thing, English is not my first language, it's my second language. So I almost always in every presentation, I almost always make up a word, almost always. So if you do pick it up, write it in the chat and do correct me. I won't get offended. I'll actually be very grateful if you can pick up where I'm making up words. So then I'd be able to correct it for my next presentation. So if you can do that, that would be great. Thank you everyone for all the good emojis that are in the chat. All right, so let's just give it a start. I'm going to share my screen, and I'm hoping that you can only see this title slide right now, which is the secret way I share my screen so I can read my notes. This is, and I usually use this pen so I can do if I was like doing in a live class where I can highlight things and I can direct your attention to different parts of the screen. Okay, so this is my pen, and I'll be using a lot of it. So I've called this presentation Complicated History. I've called it different things in different moments. I've tweaked it here and there, but I think this is my decolonizing year, in the sense that this conversation is a lot around this ongoing debate in global health, which is about decolonizing global health. And I'll explain some of those concepts as we go by. And as I know that you are not, as I mentioned, I think I didn't mention it, but I'm in the graduate school. I direct the global health programs there. I teach global health, and I have a couple of courses, and I also work at the T.H. Chan School of Public Health in the Planetary Health Alliance, which we also have very interesting conceptual debates, and it's very relevant to what's happening in Glasgow right now. I don't know if you've all been following. I hope you are. But I want to start because I know you are not all global health experts. I want to start in kind of where all global health conceptual debates start, which is in this paper in 2009. And some of you might be very familiar with it. I know Linda read it, at least for the class. And the intent is not for you to see this. You can't read this, of course. This is just kind of a picture of something that people do in presentations. They put pictures of the paper. And this is a 2009 paper that has actually withheld the test of time quite well. And this was a group of scholars within the global health realm that were more or less convened by an organization called the Consortium of Universities for Global Health, in which they said, we need a common definition of global health because we are a very scattered field. We're doing work all around the world. And I think a definition would do us good. So they brainstormed some sessions and they wrote some definitions, and they had different ways of achieving this consensus in which they reached that definition of global health, as it says here, emphasizes the transnational, that is kind of the things that are beyond the national, beyond the usual nation state framework that we have, right? That there's a supra level of phenomena, of processes that are happening at a transnational level that consider both the challenges, the determinants, and the solutions. And it involves many disciplines within beyond the health sciences, which some of you might be beyond the classical health science, and promotes this interdisciplinary collaboration. And is a synthesis of a population-based prevention. That is, we work through a public health lens, but we also work through an individual patient-provider lens as well, individual level clinical care. And some people have rebutted this definition, but I think it has it has lived through the test of time. So the way I understand this, and I'm going to try to simplify this in a graph, and I'm going to draw it because this is usually what I do, is you have all these global processes. So this is the world, right? If you imagine a slice of the world here, and this is a micro scale, and this is the macro scale, and here we have the meso scale or middle scale. You have things that are happening at a macro level, that transnational, that supranational level that they emphasize here, right? And so that is happening here, right? And some of those things are changes in how we understand each other. So changes in communication, right? Some of those are changes in governance. Some of those are changes in culture. Some of those are changes in how we do economics, right? But most of all, what's happening at a macro scale, right, are things, the world is becoming more interconnected, right? And that's what we call, one of the phenomena that we call globalization, right? And globalization is not new, right? But the speed at which it is happening, it is new. Things are happening much quicker. So economic systems are being brought together at a much quicker rate than what happened during the Silk Road era, right? Cultures are intermingling and creating new understandings of each other at a rate beyond what was happening during, let's say, the Crusades, right? So it's not that that globalization is a new process, it's the rate at which it's happening that is very quick. So here we have these macro processes that are happening at a global scale. And then we have things that are happening at a micro scale in our local environment, right? Things that in our local neighborhoods that are also changing at our local state, at our local municipality, that are related to all these things as well, right? And in the interaction of this, the macro and the micro, right, is where I place the study of global health. So for me, global health is very much about understanding how these global processes are interacting with these micro processes and vice versa, and how those influence health, right? That's the most simple definition of what I can think about what global health is. How these global processes interact with local processes and how they relate to health. So let's say if I am working anywhere in the world, let's say in Baltimore, to put an example, and I'm studying something like opioid addiction in the Baltimore, I don't know, some neighborhoods in Baltimore, that is happening at a micro scale. But I cannot deny, right, that there are some global aspects that are playing a role and influencing what's happening at a micro level. Those things might be things like migration or economic models that disadvantage the people that are in lower income strata. It might be things around intellectual property laws that are allowing pharmaceutical companies to push down patents and keep those patents. It might be things around international governance and how the flow of funds is allowing the United States to keep a health system that is very much unfair. It's about human rights framework and how they spill over or don't spill over into communities of color of Baltimore, et cetera, et cetera. So all those things that are global processes are affecting a local health phenomena to affect health, right? So that is what we study in global health, is that interaction between the global and the local. And of course, that's not the traditional thing you will hear in global health, because people will speak of HIV and malaria and tuberculosis and neglected tropical diseases and things like COVID, because they happen over there. And I use over there in quotation marks, right? They happen over there. It's not happening here. So there is this tension between what is global health. Is it something that happens over there? Is it something that happens to them? And I use those concepts in quotation marks, right? Them over there. Or is it something that happens everywhere? And in order to understand that this is actually something that happens everywhere, I bring this perspective of interaction, of interconnectedness, in able to understand that global health happens everywhere. It is a specific lens that we use to look at health phenomena that involves the global and the local, or what some authors called the glocal, right? So that is a simple definition that I like to work on when I'm talking about global health. And that's just the lay of the land right now, kind of the bottom line, or kind of the foundation of what I'm going to speak of right now. There were some rebuttals around this definition of global health. And of course, there were people that were publishing saying global health is nothing more than public health. Global health is just another, in Spanish we say un refrito, which is kind of where you take a lot of vegetables and you put them in a frying pan and you fry them and it just all tastes the same. So some people were saying global health is just a jumble of words that you're trying to create a new field, but it really doesn't exist. So there has been some rebuttals there, and some people might say, oh, global health is just the same old international health. Global health is just public health with a global lens. And some of that still is very much true. And because the practice of global health is incredibly diverse. There are people practicing global health that are still doing it in a very vertical, bilateral way. That is, people from higher income countries practicing health in a low income country, or implementing projects and calling that global health just because it's happening over there, quotation marks, or with them, working, right, them, the others. So that is one part of global health that still very much exists. There is public health projects that are happening at a very local micro scale that are being funded by a global health agenda that are being called global health, but are actually only happening at a local scale, but they're being called global scale, global health, right? So the boundaries here are not clear, and that is important to understand. But there are trends towards where some of these terms fall. There are buckets or trends, right? These are not separated silos. These are more concentric circles in which these fall. And I usually use this analogy that I like to call the genotype phenotype analogy to understand different fields. So this is a discussion that I've had in extensively when having these conceptual debates about the genotype and the phenotype. And I know a lot of you are from the health professionals and health professions and can probably distinguish very well what a genotype is. That is the actual code, our actual DNA, and the phenotype, which is how that DNA expresses. So I use this analogy to understand how different fields express themselves, right? So the DNA of all these fields, for the most, people will say are the same. They're about working to strive for equity. They're about striving for social justice. They're about improving the human condition. They're about lifting people out of poverty. They're about giving people opportunity. And that is the quote unquote ethos or the DNA that is driving these things. but how that is expressed in the work that actually is being done can actually differ. So I have some buckets here, or some domains in which the phenotype can actually look different. And I talk about the different epistemologies, or the different types of theories that are informing how the work is done or how the research is done, right? So think about public health, which is a field that has mostly been founded by epidemiologists. A lot of biostatistics are informing how public health is being implemented. A lot of a regulatory top-down approach that we see in public health, right? So a lot of policies that are within the public health realm are usually very top-down and are designed with expertise from, quote unquote, the experts in public health. So that is one way, right? The epistemologies can differ very much so within the field of global health, when the public health epistemologies are not so diverse. So there's this interdisciplinary or even transdisciplinary approach to global health that I like to think is much more useful. That is not just a combination of anthropologies studying culture and health, not just the economics of global health, not just the governance and the laws that govern global health, not just the diseases that travel internationally, but the combination of those creates a new understanding, and that's what we call global health. There's also the question of which stakeholders are involved, and usually that is also part of the phenotype. You can say, oh, we're all about social justice, but whose voice is included is also one way that these are differentiated. And I usually speak of the vertical approach, top down, versus a horizontal approach, which is more a bottom up. There's also the conversations around the transversal approach, which is not either or, but and, right? There is questions around the themes that are explored in each of these fields. So what are the questions that we're asking? What are we actually looking at? And like I said, in global health, for the most, I'd like to think that we're looking at that interaction between the global and the local. Whose voices are highlighted? Is it a solutions-based field versus a problems-based field? Who publishes? Where is that publication happening? Is there porosity or presence of clear boundaries within the work of the different people that are involved in these fields? So all those things are, again, that phenotype and how these fields are being expressed. So again, no clear lines here, just to show that there is a lot of still a blurriness in this field. All right, so right now what I want to do is move to a question for you all. Now just having laid through a very simple and hopefully clear terms what global health is and where we are right now, I want you to think about this question here. And maybe what I usually do in this, and I forgot to do it this time, is actually do a word jumble. Well, not a word jumble, what do you call it? A word cloud. And I usually have you participate in a word cloud. But if we can, and if you can think about this question, take 15 seconds to think about it. If you can write in the chat 2 words, what comes to mind when you hear the term critical studies? Just in the chat, I'm going to stop sharing so I can see your responses. So usually when you hear this term critical studies, you see, oh, you hear like, it's very much in the news right now, sometimes follow the US news, with the conversation that's happening in Virginia, if I'm not mistaken, with critical race theory, not Virginia Rotherham, Virginia's a state, with the conversation around critical race study. Critical race studies is a branch of critical theory, right? It's the application of critical theory or critical studies to race studies, right? And we see these in gender, we see these in economics, we see this in Marxist theory, we see this throughout the social world, very much so, the social sciences, applying critical theories or critical studies. So I see some here, racism, colonialism, intersectional analysis, philosophical questions, life-changing, equity and timely, deep dive, debate, opinions, topics that affect a large amount of populations. That's more than 2 words though, Marcela. Just kidding. All right, so these are great. And these are usually the conversations that have. happened when I present this question. There are other usually terms that come up that are very much part of critical theory, which again, I kind of, oh, you're not seeing my screen. I'm only one seeing my screen here, 1 second. There are other portions of this conceptual debate that are usually come up when I pose this question to an audience, right? That includes words like, especially when they see this little graph of this fist, which usually signifies fighting oppression, right? And a little brain. So it's thinking through the different power dynamics that are leading to a result that we consider unfair, right? And I'll throw out a definition that is more formal in a second. But when you think about different power structures, be it gender, be it economic, be it race, be it whatever power structure you wanna, ageism, disability, etc., what you are trying to delucidate, and I hope that's a word because it is in Spanish, in looking through things through a critical lens is power structures, right? You want to expose, you want to challenge dominant social, economic, cultural, political structures that are leading to unfair power dynamics that are usually leading to unfair results or opportunities, right? And that's what all critical studies are about. You're looking through things through this power lens, and it allows you to reflect and critique, right, society in order to challenge and reveal these power structures. And that's what usually we do when we look at things through critical lenses or critical theories or critical studies. And so some of those words include things like inclusion, fairness, opportunity, diversity, justice, feminism, privilege, power, oppression, emancipation, equity. All those words are usually part of this word cloud, and I know some of you wrote some of those in mind. So when we apply the critical lens theory to the field of global health, right? When we apply this, trying to delucidate, trying to expose and challenge the power dynamics that live in our field, we have a very interesting question, because we have to start looking at the past. We have to start looking at the history of global health to understand where we are right now. So I'm going to go through a little bit of that, of what has been more or less the consensus of how the field of global health has come to be. And I'm borrowing here from several authors. I have this book here called The History of Global Health by Randall Packard. I also borrow from Jared Diamond's work, Yuval Harari's work, Steven Pinker's work, among many other authors that are writing about these things, both from the global south and the global north. And I use those terms not to kind of throw clear boundaries around, but just to be able to understand that there are, in today's world, more or less two types of divergent communities that have sometimes been called have and have-nots, and they're not necessarily the same as the geographical boundaries of north and south. It's just a generalization that I use sometimes to simplify, which I know I shouldn't always use it, but I always clarify that I'm aware of the distinction. So when you think about the history of global health, we have to go back a little bit to this colonial period of where global health is happening right now. So if you take the places where global health is, quote unquote, happening, and remember, for the most, global health happens everywhere if you're studying it through this global lens. But where people say where global health is happening, you need to look at the colonial histories there. And for the most, when you look at the work that is being done, a lot of the work is being done in what used to be colonies of the European powers. So the European powers, the big European project, or the colonial imperial project, more or less we can trace back to the 15th century with the expansion of some of Portugal's holdings into Africa, right, to the exploration of finding new routes to the Indies. And from there, that exploration led to other big powers or big cities in that moment, those capital cities of what the imperial powers were. We're talking about Lisbon in Portugal, we're talking about Madrid in Spain, we're talking about London in England, we're talking about Paris in France. And there was this thought that the world was limited in its economic size, right? That's what we call the mercantilistic theory in economics, where there's a limitation to growth. And the only way to become more wealthy is taking from others. the concept of an economic expansion didn't really exist without understanding it as I need to take from others. So there was this struggle to try to grab, basically, almost like a land grab and resource grab, as much as possible to grow my economic power without the understanding that we can actually work together and benefit. So that is driving a lot of this. But other things that are driving this desire to colonize are also scientific, quote unquote, and I'm using scientific there in a very loose and manner, scientific theories that were saying the European white person is superior, and then there is this inferior type of person that needs to be rectified, that needs to find progress, that needs to come into the age of civility. And so the Europeans were obviously justifying through the economic and kind of this, in the name of stability, this removement of power from what they were finding as they were exploring through the world, Africa, Asia, America. And they were not just trying to remove those structures of powers, but they were also trying to extract what they were finding. And these things were things such as minerals, but also people. And although the Europeans did not invent slavery, they did take it to a level that really was something that changed how the makeup of the world and the demographics of the world is today. And this is why we need to speak of this. And like I said, very much the colonial project was based on this notion of superiority that led the colonial powers to justify, even through the use of institutions like the church, to justify what they were doing in the world. So we need to start there, because a lot of what's happening in global health today relates to what happened in that period and how different structures of power, again, using the critical lens perspective, how that changed what was going on in the world and how it created power dynamics that we still see today. But there's also very clear directions, clear relationships between what is happening in the world of health with this colonial history. And we have to recognize that in this colonial project, this expansive imperial project, there was a very important role to play by doctors and other forms of health professionals of the time to keep this colonial project growing and expanding. In the picture there, you see a painting of Patrick Manson, who was a British doctor who is called the founder and the father of tropical medicine. His book today, Manson's Tropical Diseases, is still the go-to textbook for tropical diseases. And some people have gone as far to say there are no diseases of the tropics, there are only diseases of the impoverished. That to make a clear connection that what some of these diseases are not only happening in the tropics, but they're only happening in places where there is very little hygiene resources in place. So, of course, we know by different accounts, and we have accounts from different places of the world, including the United States, on how these racist ideologies were feeding into the field of health, right? And medical apartheid is one good example of what was happening in the United States. But just like that, there are other examples that we can borrow from. So Patrick Manson there, he's experimenting to try to understand how filariasis is transmitted from people to people using a vector. So he is kind of touted as the first person who was able to understand how filariasis is contagious through a vector. And so their research obviously helped then keep the European powers in the highest kind of regard in the knowledge of these quote unquote tropical diseases, in order not to heal or treat the diseases of the people that were living there, but how can then Europeans use that knowledge in their advantage in order to increase their presence and increase their power in those. And as it says in the slide, we're talking here about how to maintain this superiority in order to support these extractive industries. And the concern there was that there were diseases like malaria and yellow fever that were killing off the Europeans that were trying to embark in these colonial imperial projects. So that also to say that, again, just emphasizing how even the textbooks in that time were talking about these racial differences that, I don't know if you've seen some pictures of people measuring noses and measuring the forehead and measuring the jaw and trying to categorize people in different races. That was all pushed through the medical establishment of the time. So again, trying to justify those medical theories that were at the time pushing the colonial project. And what we have today, we've moved away from the colonies. Of course, most colonial establishments of the time have become now independent. But what has happened is that the power structures that were there before in colonial times are very much still present in different ways that we call neo-colonial. And the neo-colonial approach or the neo-colonial lens or the neo-colonial spillover is still very much deeply rooted in this strong legacy, right, of unjust social, political, economic systems that have been there since colonial times. And because of that, it actually spills over into public health in many forms. One of them is assuming, right? One of the ways that this assumes that this neo-colonial lens or consequences spill over into public health, it's assuming that some of these less economically developed nations, lower middle income countries, have health problems that only people from the global health or from the global north or high income countries and advanced technological economic nations know how to solve. That is one way. And this is kind of, we're meddling through different assumptions there, but it also assumes that these communities do not have these assets, social, economic, cultural, that are of value, right? And a lot of times we still use terms such as, or some public health authors are still using terms like ignorance or uncivilized. And this deficit model really then spills over on how we verticalize public health problems. And this new colonial approach has been summarized by Dr. Perez Escamilla at Yale in four ways. So one is the top-down approach that I was saying, in which solutions happen with very little consultation with local community. The two is this strong emphasis on this magic bullet, or what we call techno-optimism as well. Three, there is this idea that public health should be improved not only by the very value of health, but also for the profit of some nation in higher income country, that is the exploitation or the profit from populations in lower middle income countries in the form of economic development for some and not all. And then the use of this soft power, diplomatic, economic, or other forms of soft power that then can gain an influence, that the high income countries are able to gain an influence in the geopolitical agenda that is relevant at the time. So those things are the things that you are seeing in this arc of narrative. And this is an arc that goes more or less like this, right? From the kind of outright colonial to the neo-colonial. And what you're hearing here is this picture of what happened after the Haiti earthquake, in which the US, I don't know, some of you might remember this, in which the US flooded the Haitian market with rice and grains to try to help the Haitian community. But again, they didn't consult appropriately what happened or what the consequences would be of this flooding of rice. And what happened is that all the rice farmers, which were many in Haiti, lost their livelihood and have not been able to recover from that economic blow that happened when the United States flooded the market with rice. And again, this is happening in the name of global health, right? And again, this kind of ingenuity, this optimism that something simple, a simple solution is going to solve a complex problem, like a structural poverty that is happening in Haiti. So just some considerations here about this arc of narrative that I will, hopefully we can discuss in the Q&A. So I'll start moving a little quicker here because we're almost out of time. This is how relevant this kind of this conversation has this is the relevance it has taken in the last previous years. And some people say this is a fad, and there's some even very ugly conversations happening at the APHA, the American Public Health Association, in which people are calling this a fad, and because this is a trend of publications that include things, the title health and decolonization or neocolonization. As you can see, there's a high volume of publications that are being put out there that include these terms. So because of that, people are calling this a fad. But the reality is that this is not a hot topic. And when you look at the literature from the Global South that is coming out from authors that are trying to put their lived experience and how they're living and understanding these neo-colonial approaches, this has been around for many years. And I left some of the original covers here because they look old and because they are old. These people were writing in the 50s, 60s, 70s. And I'm talking about people like the Palestinian American Edward Said. I'm talking about the Brazilian educator Paulo Freire. I'm talking about the French Caribbean author Frantz Fanon, the Kenyan author Ngugi wa Thiong'o, the Maori author Linda Tuwai Smith, which are writing about decolonization much earlier than what our Western Scopus indexed authors are doing. So when you look at the literature here, right now, it is coming very much from the West, quote unquote, the West. But when you look at historically, the literature is very much coming from the Global South, or authors that are living in lower middle income countries, or authors that are living in previous colonies. So this is not a fad. This is something that has been in the literature for many, many, many years. And it is only now that the West has taken an interest because of the use of critical lens, because of the use of these lenses that allow us to understand that there are inherent unjust power structures that are driving the field of global health. And again, the questions around this is who are making the decisions, right? And even before that, who decides what a problem is? Who gets involved in those conversations around what a problem is, right? Who is the one making the decisions and the funding and the activities, the design of those things? Who is reaping the benefits of these interventions? Are there people being left out? All those questions are being asked right now in global health in order to improve our field. We recently had a conversation at UMB through a global health summit in which we invited people from different parts of the globe to give us their perspectives on the particular issue of education and how education can live up to the critical lenses that we want to use in order to see global health through this critical lens, global health education, in order to start asking questions that relate to this. So what is decolonizing global health all about? And this is just my reflections. This is not the reflections that reflect all people of all lived experiences. Of course, being representative of all perspectives is incredibly hard. But when I speak of decolonizing global health, I usually think of these four things. There is the aspect of rethinking, right? The looking at the theories that are informing our work. And this is, again, the epistemologies, a conversation, the phenotype conversation that I mentioned earlier, that have, for the most, gone hegemonically imposed. That is, we have normalized and have brought to kind of consider this the status quo, and that now we need to start questioning, right? And some of that relates to looking at our history and how things are happening right now. This is about also appreciating distinct knowledge systems and worldviews so we can incorporate meaningfully and truthfully, and from the start, these different worldviews and perspectives that can inform better solutions, but it can also inform better ways of understanding challenges and health in health. This is about creating environments of equitable collaboration and partnerships that will allow the voices to be heard equitably, that it goes beyond this tokenistic approach in which we kind of just tick the box and say, oh, this person participated, so there is representation. It's much more than that. And we have to create those environments, both structurally, but in the sense that the policies that drive how solutions are sought, but also when we're implementing, we need to make sure that those policies are implemented beyond that tokenistic approach. And then rethinking about those power dynamics, right? Rethinking those power dynamics and finding new power dynamics that are fair, right? That reflect that shared responsibility, that considers things like history, that consider things like previous power structures that have led to unfair consequences. And when you look at this, this is all part of those elements of critical studies or critical theories that I was talking about today. Now, again, we're just starting to do this in the field of global health. In the field formally of global health, we are just looking at it from a couple of years back. And there's different initiatives that are emerging throughout different parts of the world that are trying to answer how can the field of global health be decolonized. And some authors have even asked, would even the field of global health survive its own decolonization, right? Or do we need to burn it all down, start from scratch? So what is happening? Where are we now? These are conversations and these are questions that I'm borrowing from Quentin Eichbaum, who is looking at global health and decolonization. And we are asking about, once we dismantle these power structures, or we reveal them, who is going to benefit the most, right? And the way we then decide to move forward, who should benefit the most? Now, obviously, the question, it's almost obvious what the answer is, but that is not always the case. We always find ways to justify our work so it benefits the people doing the work. And that might be something like in the form of academic currency, in the form of grants, in the form of improving economic output from a nation that then benefits another nation, integrating. So there is different ways here that we can look at this question, who is decolonization for, and then try to design solutions based on that answer. And then there's this question, how to decolonize, right? We're talking about decolonization, but how to actually go about it. And Dr. Eichbaum differentiates two different things here. One is the structural, right? How we do partnerships, how we decentralize aid, how we decentralize knowledge, how do we use frameworks and policies and programs and kind of more programmatic elements that will allow this concept of justness and historical oppression and fairness and equity to be incorporated in our global health work, right? Those are the structural, but then there is the more cognitive, the decolonizing of the man and the mind, our biases, our common history, our shared experiences. How do we go about then making sure that in our actions, we are not just perpetuating the issues that has happened before, or just calling it different things, but doing the same thing altogether. So these are still questions that we are struggling with. This, just to summarize, how do institutions become decolonized is one question. How does the work of global health become decolonized? And how do ourselves in our day-to-day work, in our day-to-day life, be able to walk through the world using lenses and using frameworks that allow us to then establish these relationships in our work and personal life that will allow us to live up to the values of decolonization that, again, I'm putting here. So with that, again, this was a short reflection. Well, not so short. I think I lasted around 35 minutes about where the field of global health is with this complicated history, these conceptual debates. And I hope this was useful for you. Some of this is taking the shape of different movements in different parts of the world. And it's good to see that there's a lot of intersectionality now happening within these kind of cross-pollination efforts, such as Black Lives Matter, such as the Me Too movement, such as a different power struggles that are happening throughout the world in different countries. So this is now intersecting with a lot of these movements, which is exciting to see, which is part of what we try to do when we're building a movement, is intersect with other movements that are seeking the same goals. So I'll stop there. I hope you found this useful, and I'm sorry I'm only leaving 11 minutes for a question. So I'll stop sharing. And if that wasn't very coherent, I don't know why I couldn't sleep very well last night, but here I am, and I'm hoping that was useful.
If I could just say thank you. This was incredibly helpful.
Are there any questions? You might just want to open up your mic, or you can raise your hand.
Carlos, Karen Janes has her hand up. Karen.
Hi, thank you. I just wanted to say how incredibly impactful that your presentation was, and how much I gained in knowledge and the thought process.
I'm sorry. Actually, my speaker is off, so I couldn't hear you. All right, I think I'm good now.
Okay. I just wanted, it was great. Like it was, I just want to tell you how great it was and how impactful the message was, and how impacted I am in sitting back and seeing how global health and this movement in decolonizing global health is intersecting in those places, in the movements of power struggle and critical thinking that we're dealing with in our country and in the world in general, in this sort of idea of species superiority and taking care of our world. And it comes down to a shift in value and principle and how we view each other in this space that we share together on this planet. And I'm very much inspired by this movement, and I'm almost to tears, you know, that that maybe it is going to take the dissembling of governance and dissembling of structures and this top-down approach where, you know, no one is heard. And so I'm just so thankful for all of your work, for all of your sightings. I would love to have a maybe just a little bit of the books that you quickly referred to regarding global health and the authors. And then, yes, thank you. Just bravo. Thank you.
Thanks, Karen. And you bring up such an important word there, which is values. Now, I do a whole nother conversation around what are we doing in education and how can we change it? Because when we talk about what we're doing in education, right, I have a spectrum of different things that we're doing, but for the most, we're not transmitting values that we want to see in the world. We are transmitting skills. We're really good at that at higher ed. We are transmitting knowledges, and we're repeating knowledges so students can then apply them, right? And I think we're not doing enough of looking at critically the theories that are informing our work. That is something that we're not doing, and that relates to the values that drive education. So if you were to ask a question, something like, how can education do a better job at transmitting and replicating the values that we want to see in the world, right? Very much related to what we think of when we think about liberal education. How do we operationalize that in curriculum, in programs, in the work that we all are doing as educators and students? So that is a space where I work in and not completely figured out, but that is something that I like to think about. Transformative learning theory is all about thinking about values, right? And we need to, in order to incorporate that effectively at an institution like UMB, we need to change the structures of how we do education to include more critical reflection, which is something that is very hard to do, especially in learning environments that are asynchronous So there's space there for innovation. How do we do that, right? In an asynchronous, I speak from the graduate school where a lot of the learning happens in asynchronous, and I've been struggling with those questions, right? If I want to transmit and live up to the values in the education I'm doing, how do I do that in a asynchronous format, in which reflection is something that is, at least the way I understand it in transformative learning, reflection is multilateral, and it happens through different stakeholders at different points in time. It happens through community engagement. It happens through engagement with critical literature. It happens through lived experience. It happens through sleeping in your pillow and thinking about the things that you learned that night, and just going and going and going. So the way to measure that is very hard. And I'm struggling with that right now because this is my first year in a learning environment like this. So if anyone has some good literature they want to share about that and value. Go ahead.
And I was thinking that all of that is only done through presence. Like, I think the teaching of wherever the teaching is and wherever the teacher is in the teaching comes in a transformative place of understanding consciousness in that, right? I'm coming from the place that I am because I am. And that's all I can come at. And I can look at these other things and I can explore and study and we can pull it all out. I think the more voices we have in teaching bring us into a space that allows more transformative learning, because each of us is coming from a different space of presence, consciousness, experience, purpose. Thank you.
I agree with you.
Beautiful. Yeah, thank you.
All right, I don't see any more questions. Just for the students.
Carlos, I have a question. I think language fails us sometimes, and well, a lot, especially in this area around how we refer to different countries. And I'm struck by, low and middle income country, high income country, global north, global south, low resource, under resource, developing. It's so often deficit based. And where are you on those terms right now?
Well, I mean, I don't want to put makeup in the fact that we still live in a very unjust world. Despite what some of the numbers say, we still very much live on an unjust world. And some of those inequities, and I'm using that word very purposefully, need to be called out very, very, very strongly. So some of this language might be deficit-based, but it is important to call that out. It is important to call out that there is still very much a huge amount of inequities happening in the world that need to be pointed at. And one of the reasons that sometimes strong language is useful is because it allows for urgency to become a tool that we use. So this is part of the conversation, let's say just the conversation that's happening in the climate world. Right, we've stopped. The recommendation is stop using climate change and start using climate emergency. So the language there is signaling that there is something inherently very wrong happening right now that we need to fix. Some of that is still, language can be a strong tool to change. Now, what we must not do, right? Difference there. What we must not do is characterize from a deficit people living in the global south. Of course, in lower middle income countries or in other ways of calling developing world, right? In the sense that when we talk about those things, we must also just make a little asterisk that says there is much more to explain here, and there are assets there that we must then also learn to recognize and work with. Right, so there needs to be a corollary to a lot of those terms that you used, Virginia, right there. But I think it allows us to at least try to think of how do we move the needle, and how do we, and again, I'm not saying that high income countries is where we want to go. Not all high income countries like the United States is a good example. Not all developed industrialized economies are where we want to go, but at least it allows us to to create what's the word I'm looking for? Discursive strategy that moves the needle. That wasn't very coherent, Virginia. In my mind, something else was happening, and then my words weren't.
No, thank you. That's very helpful. Thinking of the corollary and the asterisks. Thank you so much.
Hola, Carlos. Hi, thank you for your talk. I am from Panama, so I work here at UMB as a postdoc, and I was just wondering, how do you foster like international research collaborations?
That's a big question. And coming from Panama, Panama has one of the largest institutes of tropical medicine, tropical diseases, the Gorgas Institute,
Yes.
which is a colonial institute in itself. And this might be a little historic asterisk for the people there. And it's odd that the Panamanian government still very much lives under that paradigm. But again, it's a country that is odd and has a lot of paradoxes. How do we go about establishing research partnership? That is a very good question. And I've just gone through the process of establishing a research partnership with an indigenous territory here in southern Costa Rica. The process is not easy. I don't have the answer for that question. I do have some tips or some considerations more. One, it takes time. It takes a lot of time to create research partnerships because they should be based on trust. And trust does not come easy. So for me, the research partnership started 3 or 4 years after I started engaging with the community members. So that is not something that is easy to establish because grants have funding cycles, grants have objectives you have to meet, and the structure of the grant does not allow you to create those partnerships in a way that are meaningful, respectful, ethical, equitable. So time, if you can have it, use it. That is one way, right? Trust-based relationships are very important. So do not take that as a corollary, take that as one of the values that is driving your research partnerships. That is something very important. Value alignment, I would say, is another thing. Look for the partners that are aligned with your values. You'll find that internationally, that is not always the case because everyone is working under the same structure of grant-based research programs. And grant-based research programs are inherently unfair because the resources are usually not trickled down in a way that maintain power structures or power dynamics that are healthy for a research partnership. And by this, I mean, there's usually a lot of resources in high-income countries that are kept within high-income countries, and the decisions are made on that research project in people that are coming from high-income countries. And then the people that are collaborating in lower and middle-income countries are more of an afterthought. And the things such as equitable pay, equitable publications, equitable recognition, those things are just starting to be talked about. So I would say value alignment is very important. Time is very important. So those two things have really led, in my experience, to better research partnerships. And I know that's not a luxury everyone can have when developing research projects and research partnerships.
Thank you.
Great. I'm over time. I know a lot of you have to go, but if there's one more comment, I think I can take it before I move to my next meeting. Just write an email. All right, I think we've got it all. I put my email, I'm going to put it here. If you have follow-up questions. You got that right. If you have any follow-up questions, please let us know. Real pleasure. Thanks for joining, everyone.
Thank you, Carlos, and thank you everyone for being here.
All right, bye, everyone.
Bye.
Bye-bye. Thank you.